profound connection with what nursing can do.
How nurses becoming entrepreneurs in managing their own practice and providing the leadership.
These are powerful women.
You also develop the social care and really looking after the whole community in a very integrated, supportive way.
Japan's aging population. But guess what? Now the Western world's catching up and they don't talk about it so much.
I hope not only Japanese nurses, but also global nurses can make very close communication.
Hello, I'm Kokita, Chair of Sasakawa Health Foundation. It is a great honor for us to be the co-organizer of Nursing Now Forum in Japan today. I am a pediatrician by training, and after practicing in a hospital for some time, I joined the field of international health assistance and worked as a doctor and a health official in many developing countries. Then, when I came back to Japan, I took up a teaching position at Japanese Red Cross Kyushu International College of Nursing, and I've been with Sasakawa Health Foundation since 2013. I've always been working with nurses ever since I graduated from medical school, but it is when I went abroad and witnessed nurses being the only providers of health care where there were no doctors or no hospitals that I truly realized the power of nursing. And one of the reasons why I chose to come back to Japan and teach future nurses is that I wanted to bring our country's best nurses to every corner of the world. The world didn't know about Japanese nurses, and they were simply invisible to them. And that is also a reason why we decided to co-organize Nursing Now Forum in Japan, and it is a true honor for us. Thank you very much. Before we start, let me take a few minutes to talk about why Sasakawa Health Foundation launched this program with such a lofty title, Social Innovation by Nurses. The Japanese society has gone through the shift from rapid population growth and economic growth to rapidly changing, rapidly aging, and economically stagnant society. Healthcare costs have been increasing and continue to increase in the future, making it more difficult to maintain our universal healthcare system. At the same time, the disease structure has also been changing from dealing with treatable acute diseases to preventing non-communicable diseases. We are going through the transition from cure to care, from healthcare in facility to healthcare in community. And in order to make this transition successful, we need to change our mindset. We need to wean ourselves from the dependence on doctors and hospitals, and I believe that's exactly where the power of nurses is needed. If you take a look at the history of home nursing and visiting care in Japan, it was as early as in 1888 that the Association of Hired Nurses was founded. But the adoption of the home nursing services was very slow to pick up. In fact, we're still in the process of developing the system and institution of home nursing and visiting care services in Japan. Of course, more recently, we've seen more home nursing stations and more nursing facility complex, such as small-size, multifunctional residential nursing care facilities called kantaki, being built around the country. That is, I think, the direction we are headed in Japan. But the actual number of nurses who are working in the home nursing visiting care facilities is very small yet, at only 3.5% of approximately 1.4 million nurses working in Japan. Good news is that over the past decade, the number of such facilities has been growing rather significantly, and that is why it is extremely important to train nurses who will work in those facilities, and that's exactly why the Sasakawa Health Foundation launched this program. Here's the vision of our program. There should be more home nursing centers, or what I call castles for nurses, in each community, working in close coordination with the local healthcare resources. Also equally important is the accumulation of evidence of home nursing activities at the home nursing centers, as you can see on the right side of the screen. Another important function of the nursing home center is to provide support for community activities and to make the community stronger. What we try to get at is to realize social prescriptions, if you will, by nurses to the community. Anyway, this home nursing center is a castle for nurses. This is where nurses are stationed and working together with local healthcare resources. Today, there are 74 home nursing centers being operational in 25 prefectures in Japan. As of 2020, a total of 110 nurses have been trained, and 74 of them started their own nursing business and opened 84 offices around Japan. The number is projected to be more than 100 offices this year. And these facilities, as I mentioned earlier, are working to collect home nursing evidence, changing the mindset of people in the local community, and to become the center of primary health care in the community. From here, I want to hand over to Ms. Kanaya, who is a member of the inaugural class of our program, to take us through the rest of our discussion. Thank you. Thank you for the kind introduction. I'm Masuko Kanaya, founder and CEO of Homei Foundation. Thank you for tuning in. I opened a home nursing station in Isehara, Kanagawa Prefecture, back in 2007, and I've been managing this facility for the past 13 years. Today, we run 4 offices, including a satellite office, 2 residential care facilities, a Kentucky facility, small-size multifunctional residential nursing care facility, which was opened on March 1st, 2020. I'm honored to be one of the moderators for this global forum today, and thank you. So let's get started. In this session, we are going to hear presentations of 3 experts outside Japan and 3 of our Japanese colleagues. The first speaker is Professor Judith Chaman, past president of International Council of Nurses. As we all know, the ICN is a federation of more than 130 national nurses associations representing over 27 million nurses around the globe. Professor Chaman served as president of ICN from 2013 to 2017. She is also the former president and CEO of the Victorian Order of Nurses, which is a nonprofit charitable organization founded more than 120 years ago in Canada. VON is one of the largest national healthcare organizations with a staff of 6,400 supported by 6,200 volunteers and a pioneer in the field of home and visiting care. Today, Professor Chaman is going to talk from the global perspective about the role the nurses are required to fulfill.
Ladies and gentlemen, I am Judith, the immediate past president of the International Council of Nurses, and I am delighted to be with you through technology. I wish I could be with you in person. I cherish my visits to Japan and spend time with the Nippon Foundation, to my colleagues with Dr. Kita, with the Japanese Nursing Association, which is an amazing member of ICN, the Ministry of Health, and the nurses in Japan. I want to bring you greetings and congratulate you for hosting and launching Nursing Now. You joining hundreds of other organizations that have taken on the Nursing Now challenge and have done great things in advancing the health and nursing in their countries. So congratulations and have a very productive day. And I do hope that soon enough I can meet you all in person. All the best. Good morning, everyone. I am delighted to join you and give you a presentation on the Year of the Nurse and the Global Health Agenda, and talk about the role of nursing and the role of home care, which is very important given the current reality. The State of the World Nursing Report was released April 7th. It's a massive document that each and every one of us should become somewhat familiar with. It's the first ever snapshot of data about the global nursing workforce. The State of the Nursing, the World Nursing Report has 10 key actions, and I'm not going to go through all of it, but if you see some of it, we say it talks about shortage of countries will need to invest in nurse education and employment, monitor and ethically manage nurse migration, which is not such a big deal in Japan. Nursing leadership and governance are critical to strengthen nursing workforce. Countries should plan for a gender-sensitive nursing workforce. This is a big one. And number 2, to strengthen capacity for data collection and analysis. We don't know enough about those things. And number 10 is something that you're actually exercising now. Collaboration is the key. To move forward the health of the people and nursing care, whether it's in the hospital, home, community, like you have in your Kentucky centers, is collaboration. Let me turn now and talk for a couple of minutes about the global agenda. What are the big things that the world is worried about, in addition to COVID-19, which it seems to take up most of the energy at this point? But we cannot forget all the other issues that we have to deal with. Universal health coverage, which means that every single person in this world should have access to healthcare. And we see it more than ever now that we're talking about mass immunization. How are we going to get to those remote areas, and how are we going to give it to people who are underserved and have challenges? When I was in Japan for the Mahidol conference, the last one that was held, I went out to visit some communities where nurses led incredible community programming and community efforts. So we need to understand how we're going to deliver universal health coverage. And in many countries, it's a real issue. The Sustainable Development Goals, which I will get to in a minute, is another issue. How are we going to make sure that we will achieve the 17 targets that are set out, that includes health, poverty, education, gender issues, and we need to have a clear agenda of how that will happen. Non-communicable disease is a huge issue. There is a report that came out from OECD last week, And I looked at the information as it relates to Japan. For example, you have challenges with lung cancer, stomach cancer, breast cancer, and so on. You have less of a cardiac issues. And then what really reminded me some of your non-communicable diseases and not chronic diseases is your rates of injury and death. And your rate of death is very high, and it's mostly related, I think, to self-inflicted, basically suicide. And I think some of the efforts of what's going on in different countries when it relates to injury and so on needs to be dealt with. Human resources for health is another major issue across the world, and you've seen just in nursing alone, we are short of millions of nurses, but we also have problem of where those nurses work. Many of them work in cities and don't work in rural areas. Aging is also an issue, and interestingly enough, this OECD report said that in Japan, if you reach the age of 65 and you are a man, you're likely to live until the age of 89. And if you are a woman, you're likely to live until age 95. And hopefully, you live those years as healthy. And a lot of it depends on home care and community care and social support, because none of us, whether we are 80 or 90, want to spend the rest of our life in hospitals or other settings. We need to strengthen the health system, and we need to worry about man-made disasters and other disasters, and you are very familiar about earthquakes and others, and of course pandemics that I don't think today we need to talk about because we're all familiar with. So this is the Sustainable Development Goals, and I hope you are all familiar with it, because we could spend a whole course just talking about the SDGs. And these are goals, and there are many, many of them under each one of the 17 categories that needs to be met by 2030. I have to say, we have to pay special attention and make sure that we are integrated in moving forward. And of course, a lot of discussion is about goal number 3, because it's about health, but there is no health when there is hunger or poverty, or there is no gender equality, or there is no clean water. Dr. Tedros said, nurses are the heart of most health teams, playing a crucial role in health promotion, disease prevention, and treatments. As health professionals who are closest to the community, they have a particular role in developing a new model of community-based care and supporting local efforts to promote health and prevent disease. And Florence Nightingale said in 1870, hospitals are only an intermediate stage of civilization, never intended to take in the whole sick population. May we hope that the day will come that every sick person will have the opportunity to share in a district sick nurse at home. And what Dr. Tedros said in 2019 and what Florence Nightingale said in 1870 is what Dr. Kokita, the Nippon Foundation, the nurses that are part of this direction are you doing, and providing incredible example globally. You do it locally, but what you're doing needs to be spread globally, because what you're doing is an exemplar of how we can move home care and social care forward. So I hope you take a lot of pride in what you're doing. So now we're getting to the second part of the presentation, which talks about what is community and home-based healthcare. But there are major trends that affecting home care that needs to be kept in mind and keep moving the policies at the government level and the programming in the district level and so on. The population is aging, and Japan again has a perfect example. And I think you had the largest number of people who live to be 100 and older in the world because of your system. There is a growing number of chronic diseases, changing family structures. There are many countries and many places where the families don't live together, so seniors or aging population lives alone and they need support. Cost effectiveness, new technologies, which is really essential, and nursing workforce crisis. So we need to understand that all these 6 trends affecting home care and contribute to developing and making sure that we keep moving with building a strong and developed home care. The home care team composed of many different people. First and most, it composes the person who needs home care. And very often, the people who are at home, and when they are alone, they deliver a lot of the care for themselves if they are able to. Then there are family caregivers. And there are many studies that show that family caregivers are a very unique group of people, and oftentimes they are also get sick, they need support, their mental health needs support. It's quite a difficult undertaking, but family caregivers deliver a lot of the home care. Of course, nurses who are there to assess, advise, teach, support, and care. And then health and social welfare personnel. When I was the president of the Victorian Order of Nurses, every day we delivered over 9,000 meals to people who lived alone who couldn't cook. But if you don't have food, all the best nurses in the world and all the best family caregivers, you're not going to be able to manage because you need your nutrition and nutrients. Community health workers and community volunteers. And I can't say enough about the importance of community volunteers. And those are usually people who know you from the community or from the church or from other places, and they understand your culture and able to be supported. What are some of the future directions of home care nursing? We need sufficient resource allocation, elaborated policies on roles and responsibilities, efficiency of outreach program, and creating new opportunities for nurses. And one other thing I would enter here, evolving technology. We need to respond to emergency situation, specialization to home care and community nursing like you do it. It's not enough to say, I am a nurse. Home care and community nursing is a specialty, just like critical care is a specialty, like cardiac nursing is a specialty. We need to support for self-care so people can look after their own health and be independent, whether if they have diabetes or other problems. We need to strengthen the community system so they can support home care, promoting well-being overall. The Canadian system is good to understand, but it's not spread across the country equally. Our national healthcare law does not include home care. So home care is different everywhere. Each province has a different funding element for home care. Private and out-of-pocket and public spending is around 6% of total healthcare spending. And we rely heavily on unpaid workers, both family and volunteers. So we don't have enough healthcare workers to do home care. And we know that 1 in 10 people provided some supportive care to somebody at some point. So when I had my knee surgery, I had my children, I was in the hospital only 24 hours. But my family, my daughters who don't live in Canada, came to take care of me. Okay? So the notion of supportive care is alive and well because it's needed and the system doesn't provide enough care. I came to the end of my presentation. I think what we need to realize that the role of nursing in home and community care is very important. Nurses need to be in policy advisor position, community partners, industry partners, especially as we look at technology development, system leaders, caregiver, team leaders, educators, and researchers. So as you can see, nurses have to fill a lot of very important roles. And in conclusion, let me tell you, this is a say from Florence Nightingale that we celebrate her 200-year birth anniversary this year, the year of the nurse, and for nursing now. And she said, unless we are making progress in our nursing every year, every month, every week, take my word for it, we are going back. So I want to congratulate you for your efforts of moving forward, building home care in Japan for your amazing population. And I am wishing you all the best and a very productive conference. Thank you.
Next speaker is Dr. Marla Salmon, former dean and currently professor of nursing and global health, in charge of public policy and governance at University of Washington. Dr. Salmon put her energy on global human resources and empowerment of women for development of healthcare policies and skill development. Dr. Salmon has been engaged in studies in enhancement of healthcare system and services through entrepreneurship of nurses and midwives. Today, she will talk about what are the expected effects and potentials of investing in these enterprises.
Thank you very much for this honor to be here. It is my great pleasure, and I love having the connection with Japan and the nurses of Japan, and especially with this opportunity to celebrate the Year of the Nurse and to recognize the great honor it is to be working with the Sasakawa Foundation and also with the Japanese Nurses Association. And I want to particularly recognize and express my appreciation for Dr. Etsuko Kita, who is not only a dear friend, but has transformed nursing around the world and in Japan. And her vision takes us a long ways into the future. And it's my pleasure to be a part of the discussions of where that will go in the future. So thank you very much for this pleasure and this honor. So the focus of my topic today is on the empowerment of women and strengthening health systems, with a particular interest in what contributions there are that nurses and midwives can make through their development and their engagement in enterprise. So let me be more specific about what we can do for the session this afternoon. The first is I'm going to talk about the work that has been done that is leading to today and what it is that's our platform for discussion of nursing and midwifery enterprise. And the second is actually delving into that topic and to the landscape and all of those contextual forces that are a part of shaping the future of nursing and midwifery enterprise. And then last, my hope is that this will set the stage for a very rich discussion. And given who is attending this conference, I think that there are a lot of very important experiences that will be discussed, as well as perspectives. So the overall aims of this discussion and the project itself are to focus on improving women's lives and strengthening health systems and services. And one would think that that's pretty much what we are all about as nurses, and those of us who are nurses and also midwives. The rationale for caring about this, for focusing on it, is it's the key to the ongoing development of nursing, women's well-being, and human well-being. In other words, we're at a pivotal moment that we're needing to look at how we can continue to improve health and how we can continue to develop nursing and midwifery to make a difference in the world. The global backdrop, what is happening around us, is almost unprecedented. If you think carefully about the health challenges we're facing, and of course, COVID is in all of our minds as we think about it, but COVID is one of what we will see in the future, many communicable diseases. And part of what we're dealing with as well is our changing demographics, not only in terms of some groups and societies aging, but also some countries experiencing demographics of young waves of people coming in. And then we see migration and immigration challenges and opportunities around the world. We also are facing the economic realities of what COVID is driving and what will come in the future. It's important that we as nurses and midwives do not forget what is happening in terms of our climate-driven disasters and the inequities and poverty that we're experiencing. There's a lot going on that shapes opportunity for us to make impact. And we see that globally because there's a growing reliance on nurses and midwives to try to cast ways of affording, making accessible, and having effective services. In addition, we see some driving of change in the health system from investors, individuals, philanthropy, and governments who are investing in innovative approaches to actually making better health options available. One of the most important opportunities that we have is there's convergence of gender and occupation when it comes to nurses and midwives. If we can improve the working lot for nurses and midwives, we can also improve the well-being of women because so many of them are women. So let's talk about the terrain. What is the landscape out there that's shaping nursing and midwifery enterprise? Basically, there are 4 sectors involved, and one of them is the economic and social development sector. When we think about international aid, that's part of the development sector. Investment in growing economies, that's part of development. And in the past, for the last several decades, women have been identified as a target for investment, for creating enterprise that's women-owned and women-operated. But those investments are going to largely the agricultural and the commercial sectors. Not much has really gone yet to the health-related sector. Although I have to say what is happening in Japan and the community health centers are wonderful that the Sasakawa Foundation is funding. And that's one great example of philanthropy investing in an important solution. So the health sector has a long history as well, increasingly, of empowering women through service delivery. What this means is that the health sector has been providing services to women to try to ensure that they are healthier, that they have healthier childbirths. And so that's been an important factor in improving the well-being and the empowerment of women. But unfortunately, those same investments aren't taking place as much as they should in terms of the women who work in health systems. So investing in their well-being, investing in what they can do to own and operate their own enterprises. And then we have nursing and midwifery in general, and that's empowering women through the services that we provide, our organizations, our collective action, how we volunteer, and nursing and midwifery actually as a career opportunity for women. But lastly is this whole investment sector and the increasing investment globally in investors investing in rapidly and creatively growing health opportunities and innovation. So enterprise is growing, it's being invested in. Now, if you look at this schematically, here's the terrain. And what we're talking about for nursing and midwifery enterprise sits in the smack middle of 4 different sectors. So we see that nursing really can, and midwifery really can, take advantage of the opportunities that sit in those sectors and the forces that are shaping it. But this means that we need to think about what we're doing. So let's talk about work that's leading up to today. It comes from the field. Those of us who have worked globally know that nurses and midwives are doing remarkable things out there. We also know that many of the things that they're doing are things that are run by other people. Who knows best about nursing and midwifery work? It's nurses. How can we change the fact that they don't often own or operate their own enterprises? And that's where the research in nursing and midwifery enterprise comes in. And that research is research that we have undertaken with the Center for Health Market Innovations. And it was a landscaping study that we looked at, finding as much as we could about nursing and midwifery enterprise and women's empowerment. The project that we did looked at 1,237 documented projects that were in a database of projects globally from 129 countries, and there were 9 other sources of information. We ended up with 94 programs that we looked at, and what we found was that many of those programs focused on services to women, empowering women through services. But it was very unusual for them to focus on empowering the women who were working in those programs. So the irony was that we found a lot of programs that were providing and empowering services, and empowering women, but we really didn't often find those that also empowered the women who were in those programs working, the nurses, the midwives, and others. Here's a bit of a map representation of where we found those programs and what they were. 46 of those programs focused on nurses, 25 on midwives, and 23 on both. They were all around the world. The most prominent were in India, Kenya, Tanzania, Uganda. And these were all lower income countries. And I want to stress here that we see some of the most innovation taking place in those countries. And we don't completely understand it, but we believe it's because of the great need and also the willingness to try innovative solutions that aren't necessarily restricted by some of the restrictions that we see in some of the more economically advantaged countries. The interesting thing about the programs that we saw was that many and most were focused on maternal and child health, some on primary care and some on both. So you see that we have examples in some cases of focusing on more than one. But the challenging pieces of this was that we saw very little focus on mental health, nutrition, dentistry, some of the things that are so important to the well-being of people, particularly if you're looking at some of the older populations. But these were the focuses, and we have a lot to learn from those as we go forward. But what did we learn? And these are lessons, in a sense, that represent the potential of what we learned. There's much more work to be done. But what we can draw from this is that there's great potential for nursing and midwifery enterprise to enhance both the reach and the impact of health systems. Nurses and midwives often are in places where no one else is in terms of healthcare providers, and they are naturals in terms of providing services. So that reach and also the absolute effectiveness of their services makes a huge difference. We found, too, that there were valuable opportunities for women and girls, not only within nursing, but that nurses and midwives could be wonderful models for helping women and girls in their development, and that these nursing centers and midwifery centers, regardless of what population they serve, could be community hubs and have spokes that reached out to engage and empower beyond the actual services that those nurses and midwives provided. We saw tremendous ownership and employment opportunities for women and for nurses and midwives, including staff and community health workers. And I want to make a comment here about community health workers, because often community health workers don't have the support and the frameworks within which to grow in practice as health professionals and perhaps even become nurses and midwives. So it provides career ladders, and it provides opportunities for them to continue to learn and develop. Great potential for leadership development opportunities, not only from the perspective of management and administrative opportunities, but also within communities. And this is really reflected in the last one, which is we saw that when a nurse or a midwife owned and operated their own enterprises, they were often engaged in other things in the community, civic engagement, and societal standing. So they occupy places in their communities of leadership in many cases. So these are the potentials that can come out of the enterprise arena, and how they strengthen nursing and midwifery, but also empower women and strengthen health services. As I say, there's much more research to do, but there's much promise. There are challenges. There are reasons why there are not a great number of these kinds of programs around the world. So we found within the models that there were things that could be done to actually enhance the possibility and the likelihood of nursing and midwifery enterprises. First is to learn the models and learn about the models that seem to help to foster the development of these development of these enterprises. We found that collective enterprises, networks of more than one enterprise, one clinic, one service center, that those networks were essential. They could be social franchises, they could be co-ops, or just networks. And sometimes they provided financing, sometimes they provided just the support around good quality care. And they're actually quite important. And so for sustainability, health impact, and empowerment, looking to social franchises, co-ops, and networks, bringing providers and their enterprises together. We also found that it is crucial that there's leadership and business training available. It's crucial that we have the kinds of leadership and business training, and that it is crucial that it happen. So these are ways to overcome challenge. There has to be investment and supportive and incubation, startup kinds of resources and ways to scale these enterprises to a point where they are sustainable. And there's a whole area of investment, social investment, that has emerged that's called gender lens investment, which is focused on investors, social impact investors, putting their money into women-owned, women-operated, women-benefiting businesses. And so gender lens investment in the social investment sector is one that's very promising. We also found that we need to rely on developing new partnerships and approaches that reach across sectors. Those 4 sectors that I mentioned in the terrain, it's important that nurses and midwives become comfortable with and engage actively in the conduct of partnership development across those boundaries. You won't be seeing much investment without connecting with investors. You won't be seeing much in terms of kinds of things that health services at systems level can do to support without working across those boundaries. So adopting these promising global lessons and models is going to be very important if we create different futures than what we have now. We have to learn more, we have to adopt, we have to try things out, we have to learn from one another. One of the biggest challenges that we see is having an environment, a legal and social environment in which there is support for women-owned and operated businesses in general, but also nursing and midwifery-owned, operated enterprise. So to do this, we really need the activism and the wisdom of a variety of partners, the legal sector, for instance, but also our nursing organizations and our educational institutes, and our investors need to help us develop these legal frameworks, policies, contracting frameworks, sources of financing, and regulatory frameworks and partnerships that allow these enterprises to be developed, to be safely sustained, to offer quality services, and to be aligned with national and local health systems. And I want to say something particular about that. Many countries have national health systems, they have national health plans, and nursing and midwifery enterprise needs to be understood as a tremendous resource to those national health systems and plans achieving their objectives. So our hope is that as we develop these enterprises, that there are ways for them to be understood as key means for operationalizing the goals and the aspirations of those governments and their national health systems and plans. So it is also important that when we talk about partnerships, that we actually involve the partners in these activities. Sometimes when we do things as nurses, we will launch something and we might ask partners to be involved in helping support it, or we might ask partners to collaborate at the onset, but sometimes we don't see the importance of engaging them as full partners throughout the process. And without that partnership, we won't be doing all that we can do, but we also won't last as long as we should. And I also think it's important that when nurses and midwives own or operate their own enterprises, that they see their responsibility as also being the advancement of the well-being of their team members. Again, health systems have failed in empowering women within their employers. So employees need to have the support and the career opportunities and the development that is available to those who own and operate. This is about women's empowerment and ultimately about health. Again, I have to reiterate that we need to continue research. This is a global area of work, and there's lots going on that's worth looking at and worth sharing. And one of the exciting things about this conference is that this is probably the first real focus in the depth that is happening. So you're on the front end of really important development for the future. And I guess since I've been talking about the future, let me go back to the past and the present, because there's one thing that shouldn't change, and I hope it never changes, which is that for us to succeed, we need to continue to be who we are as nurses, as midwives, as health professionals, and as members of a global citizenship, which is we need to continue our commitment. We need to have courage. This is not easy work. We need to collaborate as we've known how to do. We need to communicate in the ways that were so effective. And we need to be creative, but most of all, we need to continue to care, because care and compassion is at the center of all of the work that we do and so much of what we need to do in the future. So with that, I'm going to thank you all, and just to say that there are some reports, and I will provide that information. It'll be available to you. There are reports. There are resources that can further give you information on this. And ultimately, thank you for what you do, and thank you for what you will do in the future.
Next speaker is Dr. Andre Baumann, Associate Vice President, McMaster University, Faculty of Health Sciences. Dr. Baumann mainly studies evidence-based policy and practice related to nursing workforces. In particular, she focused on employment of international nurses, which is the largest professional group of women in Canada, a land of immigration. Dr. Baumann has a long-standing relationship with the late Dr. Hinohara. She has published a book titled Leadership in Challenging Times. As a person who is well-versed in both Canada and Japan, today, Doctor will talk about measuring the value of nurses.
So again, thank you. And what I decided to really talk about is really fundamental. As you can see from my title, and some of you in the audience all know, or you'll know me, I am at McMaster, and I am involved in research, and we focus on nursing and nursing workforce issues. And our biggest concern is, of course, care, and nurses being at the forefront and the true caregivers within the healthcare system. And we wanted to talk today a little bit about measuring the value of nursing. This has been an ongoing challenge for the last few years in terms of trying to really prove empirically the value of nursing, and I think many nursing researchers have done that, and clinicians. But the struggle is not over yet. I think that in some areas we have deficiencies of nursing services around the world, and we need to support those nurses in making the argument for more nurses and better care. So my presentation will focus on that. So in preparing for this presentation, and again, reemphasizing the point, how long the nursing profession has been in existence. In fact, historically, we can see even further back than that. We can see the evolution of nursing services in the 14th century in what is now known as the Middle East. It was a different constellation of, I guess, almost empires during those times, but it's a very, very old profession. But I just put this slide in to reinforce in Canada and in Japan, really nursing became more formalized in the 1800s, sort of the later 1800s. And if you look in Japan, 1869, look in Canada, 1864. But in fact, again, like I was saying, the very first nursing endeavor in Canada, we can trace that all the way back to the Grey Nuns and trace it all the way back to the 16th century. So it's an old profession. It's growing and changing, and the roles are changing. I'm going to talk a little bit about that today. But again, nursing has an impact. It just, again, continues to struggle to have enough resources to continually maintain that impact. So we have established for quite some time that nursing is really the backbone of a healthcare system. In any country, there are many nurses. In Japan, there's over 1 million nurses. In Canada, there's close to 500,000 nurses. And large, in America, even more. And other countries, again, the same. Importantly, an area where nurses do a lot of service is in the care of our elderly and are vulnerable. So not everyone who's vulnerable is elderly, but our societies are getting older, and this is continually talked about. So the care of our elderly really has to become tantamount to the integrity of our society. And again, this statistic, 2018 in Japan, 28%, and expected to represent 30%. This was often discussed for a long time around the world, Japan's aging population. But guess what? Now the Western world's catching up, and they don't talk about it so much. They now begin to focus on themselves. So in 2020, 18% of our population is 65. But of course, this is going to grow. Now, one of Canada's solutions has been immigration, because we've got to somehow replenish our population, and our birth rate is low. In modern societies, that seems to be the trend as women become more educated, more independent, and also societies change. Societies become very expensive. People just make lots of decisions about families and starting families. But Canada is in a special situation where they have to bring in migration from all over the world in order. We have a very large country, and we know if we don't do this, that we'll soon be in a bit of a crisis around human resources. So next slide, please. It sort of shows you the landmass of Canada, and our population is not anywhere nearly as large as Japan, However, even more importantly, it's very dispersed. So we have a very large geographic area. The good part is our nursing, to a certain extent, our nursing education, our regulatory bodies across the country are fairly well integrated. We don't have to have common curriculums, but we have much in common in nursing. So our associations, our regulatory bodies, even though it's provincial, i.e. prefecture centered, there's very good dialogue between these regulatory bodies. But this just gives you a snapshot of our population growth, and you can see it's not overly impressive. So there's probably going to be issues. So the issue of care is really important, and there are differences in the healthcare models between Japan and Canada and between many countries in the world. However, countries have similarities in the way they view the care function and how it's viewed and how it's valued. If you look in Canada, and if they do it survey after survey, when they're asked, the Canadian public's asked, who do you trust more? And they'll give a variety of healthcare services, healthcare positions. Nurses always come out as very highly respected and highly trusted. So people are aware of the care functions. However, public perceptions about care, not nurses, but care, has changed over time due to structural changes. So again, how it's organized is important, because nursing services are only as good as the way the services are organized. And this has come to be something we're all reflecting on. The need for nurses is increasing. There's no doubt about that, the importance of nurses. But global shortages make it challenging for countries, especially now, to fill gaps in the healthcare labor market. So this is a very, very busy slide, and Dr. Chaman may have inserted some examples, and I'm sure she'll talk about the state of the world's nursing. This was very important for us as a document. It came out WHO this year. It's important for a variety of reasons. And again, I'm sure Dr. Chaman, country comparisons. And so for nurses that are interested looking at international comparators, this document is invaluable. And nursing leaders in country, if they're discussing nursing human resources. And so one page covers a lot. And again, this is a very busy slide. I put it in about Canada, and I don't have a lot of time to dwell on these slides, but they are wonderful. It's a wonderful piece of work, and I gave the citation at the end. It's available on the web, and I'm encouraging everyone, if they haven't read it, it's an excellent resource to get a snapshot of nursing. So picking up on what we've said before, is nurses are on the forefront, and many nurses that we've seen today, and we will be talking about today, they are on the forefront of battling the epidemic. There's a significant disease burden as a result. About 10 years ago, we had an issue of infections in hospital, and my research group became very interested in that. And because we had to take extraordinary isolation procedures to battle the infections within hospitals, tracking the daily infection rate, etc. And it added to the workload of nurses at that time. And now it's been expanded to include management of the diseases. The nurses in the Canadian study estimated that IPAC, the donning and doffing as they call it, that are mandated for personal protective equipment, added 20 minutes to 2 hours to their shifts. I just want to show you this slide. It's a very busy slide again. So this was done by Alicia Kaba, a graduate student of mine. And because we were interested in really analyzing what infection added to the daily complexities of the nursing workload. And as I said, we did this a few years back. But what these circles show you, we picked a patient or a prototype of a patient who would be quite ill. And we tried to demonstrate the number of nursing procedures one would have to do and the management of patient daily care and the type of clinical decisions, and then superimpose infection on top of it. So when we say nurses are stressed during the epidemic, this diagram demonstrates the additional workload. And this diagram does not really recognize, nor are we able to really depict the psychological stress of all this. We have published this article, so it is available. And as I said, it was written before the epidemic. And so the epidemic really has added an additional burden to nurses' work. So it's really, really important that we begin to improve our understanding of complex problems. We also obtain information by not only encouraging but empowering frontline staff to share their insights and views. And I think this is ever more important given the context of what we're going through now. The frontline staff, as you could see in the previous diagram, really are trying their best to provide care. I'm pleased to say that actually we were looking at the absenteeism rate. The absenteeism rate, because of the epidemic, of course, if you have to be absent due to being quarantined yourself, you have to be absent. But those that are not are going to work every day and really trying hard to provide care because they know how critical it is. The second point really says we really have to all work together. And I think the epidemic has taught us that. And in long-term care, they talk about that, how they realize how interdependent they are with other services and how they have to lean on other services, i.e. the services of the hospital, the services of the military, the services of the Red Cross. So what you begin to see during crisis is a much more codependent approach. People do recognize they need others. This is not something one profession can do. And nurses are very good at that. They've always had strength in making teams work together. It's been one of the hallmarks of nursing services. We also have worked closely in developing a common language to increase interprofessional collaboration and enhance problem solving. So it goes a long way with mutual respect. If teams, work together closely, they respect each other. Pandemics are a very bad thing, and it's nothing anyone would want, but sometimes what comes out of it is a greater understanding of our mutual dependency and the need to work closely with each other. So they work across the spectrum, as I said, in Canada, and true in Japan. Actually, I have a really great PhD thesis in my office. Mariko Koyama did it, and she demonstrated the work in rehabilitation. And that's a very interesting study she did some time ago. But again, it showed the issue of transdisciplinarity and what facilitates it and what are some of the barriers. Nursing practice changes when there are critical events, and the slide before really demonstrates that. When you have an overriding infection and all the reverse isolation, you're not only doing your care of your patient, you're trying to care for the families. Now, these families may not be able to visit their loved ones, so there's great stories about how nurses and doctors too trying to maintain contact with families somehow, either by electronic or by phone, to try to keep the families involved. Teamwork is essential, and I can't say that much in the studies we're doing, in the interviews of these homes, looking at what works. The leaders and the nurses' dietary cleaning services, they all talk about teamwork. But the last point is important. It's leadership in crisis is paramount. People look to leaders to give them guidance and to keep that team unified. It does put an even greater pressure on leadership to be innovative and to really stay close to their staff and try to stay as close as they can to the patients or the clients, but really stay close to the staff, because it's the staff where they're looking to the leaders to keep them going. So what have we learned in Canada? We've learned the pandemic has had a significant impact on the ability to care. We also now see we're heading for an acute shortage of personnel, and care workers have emerged. Previous to this, the focus was on the cure function, again, the technology, the physicians, rather than the care. Acute care systems were well staffed, but the community care and the care of the vulnerable are now in crisis mode in Canada. So again, measuring the value of nursing is really important. They're on the interface. The databases are important to identify nurses. Data and metrics are vital for understanding and responding to changes affecting the cost of delivery of care. I want to just spend a few seconds on this third point. When the World Health did that important piece on nursing, measuring nursing in some countries was very difficult, partly because we don't really have a standardized definition for nursing, and that does get in the way of sometimes recognizing nursing services in some countries. So the workforce analytics really are the set of data analysis tool and metrics that we have to have for comprehensive workforce planning and measurement and improvement. I'm just putting this up. I'm not going to dwell on it, but nursing is defined differently around the world. And in some countries, the definitions are quite comprehensive and followed up by ways of describing what nurses do. And I put Japan and Canada's definitions, but it's not true of all countries. And I know in a big World Bank study we critiqued, they were talking about health services and they didn't even include nursing. They include physician services that got a lot of attention. Nursing was nowhere. And they said, this is the very definition. We cannot, there's no standardized definition. This was in the Americas, Latin America, and North and Central America. So the future of caring, COVID exists and it shows us our weaknesses. We have unanticipated consequences, putting further strain on social and health systems. Our vulnerable population, increased risk, and now we've exacerbated yet again a shortage of healthcare professionals. Caring is more complex and nurses are at the forefront. So we need to focus on merging the roles and models to support the delivery of care. So the latest evidence, the nursing workforce is expanding in size and scope and importance. However, it's still insufficient to meet the rising demand. We know now there's excellent nursing studies to show that the investment in nurses contribute to health-related SDG targets: education, gender, decent work, and economic growth. Those are only 3 examples where the nursing profession plays a really important role. So Dr. Chaman's presentation will emphasizes this, but we need to invest in accelerating nursing education. Now, Japan did this. We all remember the green paper when you could see the changing demographics and the expansion of the nursing schools. And I really applaud that. That did not happen in Canada, and I still think that was a gold standard way of preparing for the future. Forecasting is showing, again, need many, many new nurses by 2013 all around the world. Focus is on countries that have very poor nursing services, but in order to give to others, we need to have strong nursing services within our own country. And we need to strengthen nursing leaders. It's imperative that nurses are engaged in and have the power to influence policies and decisions. I'm just going to end with a message from Dr. Hinahara. As you know, I had the privilege of working on a book with Dr. Hinahara because I had observed him many years ago and those of you who know him, you know he was really a strong supporter of nursing. And he really had some very wise lessons for us all. And I still find today his words very inspirational, and I can hear them in my mind. The one thing I remember him saying is, life seldom proceeds in a straight line. And this we found to be true this year for sure. The ability to review a situation and provide direction becomes even more important in crisis. And then he was referring to a leader there. He talked closely, which should inspire us all, about the role of adversity, because he himself had adversity in his young life. The real issue is focused specifically on how to address the challenges that present themselves, and more importantly, how to rise above them. And finally, he talked a lot about courage and perseverance. And he talked about innovation should be encouraged, changes should be initiated, and new ideas should be advanced. So final thoughts. In Japan, Canada, and other countries worldwide, nurses are working together to provide care under extraordinary circumstances, and they are sustaining health systems that are being challenged by COVID. Based on his experiences, Dr. Hinahara understood that in a crisis, particularly one with severe impact and outcomes, people have to walk together like mountain climbers who are bound to one another by a rope. In the hands of nurses, this rope is a lifeline. Thank you very much.
Next, we are going to listen to our three colleagues' presentations. The next presenter is Ms. Mitsuko Nomazaki, the founder of the first Kentucky facility of the home care network in the city of Fukushima. Ms. Nomazaki is going to share with us how the Kentucky facility works in theory and in practice. Thank you for the kind introduction. I am Mitsuko Nomazaki. I'm the director of Yui no Gakko, a multifunctional residential nursing care facility, which is part of the Institute of Cranial Nerve Diseases. Japan is becoming a super aging nation with an ultra-low birth rate and many deaths. And there is so much expectation for nursing services that can meet diverse needs. As our nursing care system is increasingly built around the local communities to provide comprehensive care, nurses will be required to provide care without doctors by their side, and that's why they need to be trained to know diseases and expected to provide comprehensive care to individual patients. Hence, we need a mechanism in place so that nurses will play a central and integral role in making their local community healthier and more secure. I noticed these needs when I was managing the home and visiting care services at a local hospital. Social isolation and a weakened community bond has been of particular concern lately for those who need nursing care. The elderly and those with disabilities should be supported by people in the community, and every member of the community should be able to care one another. That's why I call for a transition to a more inclusive society. Those with healthcare needs should be able to get services from coordinated professionals who know the patients and the community if they wish to continue to live in the same community. But healthcare professionals working in silos make it extremely difficult to seamlessly provide the necessary care or require a lot of energy to do so. That's why Kentucky facility can best serve those needs, because it is flexible and has staff who are familiar with those who need care and their surrounding environment. And it gives a sense of security and comfort to those who use the services and their families alike. It can not only bring the level of home care to the next level, but also push the limits of what home care provide for those who need it. Moreover, the Kentucky facility is able to provide such a wide array of nursing care and services that cut across many laws and regulations. So let me then give you a little bit more details about how Kentucky Care Facility actually works. Kentucky Nursing Care is part of the National Nursing Insurance Scheme, which supports those who are sick both in terms of medical treatment and nursing care until they see their final moment. The system originally started back in 2012 and it came to be called as Kentucky in 2015. It provides support to families when the clinical conditions of the patient changes or when families suffer the so-called caregiver fatigue, and also provides a necessary bridge of care when the patient moves from hospital to home. Kentucky provides home care support to those with high healthcare needs 24/7. Their services can be delivered in many forms, including visiting care and such. There are up to 29 registered caregivers, visiting caregivers up to 18, and overnight staying caregivers up to 9 per facility. Kentucky can also house a visiting care station, making it possible to allow short stays as well. It also accepts children, adults with disabilities who need medical treatment. Let me then talk about Yuino Gakko facility and the situation in Fukushima. This is the map of Fukushima Prefecture. The percentage of aging population in Fukushima Prefecture is at 30.9%, and that in the city of Fukushima at 29% in 2019, both being higher than the national average of 28.1%. The population of the city of Fukushima was about 280,000 in 2019 and is one of the largest cities. The area where a facility is located is called Shimizu, and its percentage of aging population is 27.3%, which is slightly lower than cities at percentage. This is how we are running our facility. It provides a wide range of Kentucky services and other residential nursing care services, making the management of the facility financially viable. Our facility provides nursing care in close coordination with other healthcare providers. We're especially working very closely with care managers and disability aid experts. And by doing so, particularly with local medical institutions, we are able to reduce the number of unnecessary ambulance dispatches. And we're serving the local community as family nurses, if you will. So where do people see their loved one pass away? From 2016 to 2019, 42% of the families who use the service saw their loved one pass away at home. 30% of them at hospital and 25% of them at Kentucky facility. About 70% of them dealt with the death of their loved one at home or in an environment that is pretty much close to at home, higher than the national average. Nurses are playing a central role along with care managers in assisting families in every step of the way how they'd like to say goodbye to their loved one at the very last moment. We're changing the mix of stays and visits as the patient's clinical condition worsens so that the family will not feel any regret when they finally have to see their loved one pass away at home. And this way, we can also help reduce the national welfare spending.
できたケースが多かったことであります。この仕組みは社会保障費の削減にも寄与できると考えます。
Let me give you an example of one of our patients last moment. This patient had a lot of underlying conditions and in need of level 5 of care, but passed away of old age. She was unable to take anything by mouth and required additional CV ports, but instead chose to take continuous drip infusion using visiting care services. Then her care manager recommended the use of Kentucky facility, so over the next 26 months, she got care both at home and at Kentucky facility. She lived with her son, who was working night shifts, so the home care plan was created to meet her son's work schedule. However, the plan was later revised in order to respond to the wish of her son to have space for himself at home at night. That change in the plan worked well for the patient as well because she was able to see seasonal changes on the way from home to the facility and get to participate in events organized at the facility. Also, interactions with familiar staff improved her clinical conditions. At one time, even oral intake was possible. Drip infusion was suspended, and she was able to chat and even knit again. Her son was also happy because he could focus on his job when his mother spent quality time in the facility. Eventually, however, the patient had to resume drip infusion, and they became bedridden again. After consulting with her doctor, the patient and her son consented to reduce the amount of drip infusion so that she could die peacefully. Although her son decided to see his mother pass away at home, his work schedule didn't allow him to do that, and in the end, on the last day of his work, just before he took a leave, the patient died in the facility. We contacted her son immediately, but because he was working the night shift all by himself, he could come to the facility only after his shift finished. After he arrived, he said, and I quote, "It ends well. My mother left this facility and I wanted to die surrounded by people she liked. I could have been panicked if she had died at home." All the staff in the facility sent her off, and her son took his mother's body home. The Kentucky facility provides nursing care services that are tailored to the needs of the users and their families, and is therefore able to have better communication and information sharing with their families than otherwise would be the case, not only at the time of the death, but also throughout the period. Close communication with the patient's doctor also enables to let the family know the latest condition of the patient so that they can prepare for their loved one's last moment well ahead of the time needed for their family to decide how they want to spend the rest of their time with the loved one. Spending the rest of their time peacefully in the comfort of their home is of the utmost importance when we try to alleviate the spiritual pain most of the families have to endure 1 or 2 weeks prior to the death of their loved one. That is something that a hospitalized patient cannot enjoy because of medication. In Kentucky facilities, we are able to give this precious time and opportunity to the family to prepare for the death of their loved one. The role and aim of a facility is not only to become a hub of coordination among the patient's family, hospital, nursing care facility, and a local government to meet the diverse medical needs, but also to provide secure and a comfortable space for everyone to get together and enjoy the time spent together. It's not only a hospital, a facility, but another home away from home, creating a community and neighborhood of nurses, care workers, therapists, nutritionists, and other staff, which will become a hub that makes the local community healthier and stronger, both economically and socially. And we also strive to be a local comprehensive provider of health and nursing care to address the changing needs of society. The nursing care community should be more involved in the affairs of the local community in the future. That is to provide support and assistance to all the members of the local community so that they can continue to conduct their daily life until the very end. All the members of the community, of course, include those with disabilities or disease, and we provide professional support to assist their daily lives. We also need to raise awareness of health and public health to prevent a decrease in the quality of health. Also, by coordinating the hospitalization and discharge with doctors, nurses, care managers, and other experts and stakeholders, we should create a mechanism that supports the local community from prenatal care through Aya generations to the elderly and grief care. In other words, we should be committed to building a more inclusive society. Thank you for listening. The next speaker is Ms. Kyoko Otsuki, who is managing a very unique Kentucky facility in a remote city of Toyoka in Hyogo Prefecture. She is specifically going to talk about nursing care in the hilly and mountainous area of Japan. Hello, I'm Kyoko Otsuki, CEO of social design Rigorese. I'm going to talk about nursing care in the hilly and mountainous area of Japan. Hyogo Prefecture, my home prefecture, is located in western Japan, and one of the most famous cities, of course, Kobe. But my hometown, the city of Toyooka, is located at the north end of the prefecture. The northern part of the prefecture is scarcely populated compared with the south, and it's underpopulated. It's a remote, rural area. This is a zoomed map of the city of Toyooka, and I'm showing it side by side with the map of metropolitan Tokyo. It's an aerial photo map, and it clearly shows that Tokyo is filled with buildings and towns, whereas my hometown is surrounded by mountains and people live in those narrow valleys. So nurses visiting homes are going up and down the mountains and valleys all the time. Also, this is a very snowy region. It accumulates a lot of snow, much like Niigata Prefecture. It's a very challenging terrain, as you can see, and its population density is about 1/100th of that of Tokyo. People in this community are leaving my hometown in droves. Only a few houses dot my hometown, and vacancy has been increasingly the norm lately. Hospitals and clinics shrink in size and capacity. Our doctors are aging and stop practicing. And that is the landscape where we actually renovated an old vacant house into a Kentucky facility.
This is the picture of the exterior of houses after renovation. And the left side, you see the old house. This was renovated to the restaurant. And Kentucky is the house on the right-hand side with black roof. This is a path to the entrance. And there is the living room right next to the entrance. And this house was built with high-quality wood, so we retained when we built and renovated this house. And this room used to be a guest house, now used by one of the users. And the upper part of all walls were also retained. And around the facility, there are beautiful nature and farm and mountain. And many of the users in the facility used to work at farm. So in order to regain their lifestyle, we are making use of those farmland and engaged in farms. And also there are big chestnut tree in the garden. And when the season comes, we pick up the chestnut and we cook rice, chestnut rice, and share together. We have less children in this area, so it's difficult to gather many children. And our staff bring their children to the facilities, and we hold Halloween event. What we do is we try to make people to use send normal life as possible. And what we place most important is eating. And the man in this picture used to be bedridden patient in hospital, and 90% of the people were bedridden in hospital. But we tried to let him eat orally, starting from 1 scoop of spoon. Of course, nurse make a physical assessment, and ST will give massage. And now he was able to eat orally. And holding eating event makes people feel eating is something enjoyable. Even people who doesn't eat so much can enjoy. And on sunny day, we have a patio. So we gather at patio and sometimes bring lunchbox outside and do picnic-like event. We cherish such kind of opportunity. By doing those, so those who had been receiving tube feeding or drip would be able to start eating orally again. Situation of the termination of contract or registration. This is the data as of October 2020. 80% of users died while using our facility, our services. Some users passed away in our facilities, where some users go back to their home and spend the last moment together with the family while using our services. And there are also users whose condition improved and level of the care needed decreased and transferred to other facilities. 10% readmitted to the hospital. And as I mentioned, this old house was renovated to the organic restaurant, since we place importance on eating. This restaurant is open to the public. This is not the cafe only opens on Sunday. So sometimes the family of the user visit here and hold a birthday event. And since this area population is decreasing, so we have to take into consideration about local revitalization. Otherwise, it will be really difficult to realize well-being of the community. So we are also making approach from such perspective. Well, I came to this local community and I was asking myself, what could be expected for nurses to make local community healthy? And what I thought was the nurses are the people with high observation skill, and they can observe and comprehend the situation of the community. And they are the people who can build communities. And if there are many nurses who are conscious of building community, the people's life will be further enriched. Hopefully, there will be many nurses who come to local community with such consciousness. I'd like to try my best to enhance community health nursing. Thank you. Next speaker is Ms. Yuko Isono, who runs visiting nurse station in urban area. Japan is aging, but challenges vary by areas. She will talk about the role of the nurse in community case. General Incorporated Association Co-Creation Chiki Marugoto Care Station Kawasaki. My name is Yuko Isono, my representative director. Our main duty is to visit people's house, and nurse visits provide care based on their level of disabilities and sickness. We provide advanced care planning for who want to spend their last moment at home. And with the advice of doctors, we provide care similar to what they receive at hospital. What is a visiting nurse do? Observe physical condition, prevention of worsening of the condition, rehabilitation. And we respond at the time of the emergency with instruction of the doctor. Now, the reason why I started the Chiki Marugoto Care Station. Chiki Marugoto Care, which means community in whole. And this idea was not my idea. It was started by my predecessors who were the pioneers of community care. This care provides integrated care to prevent aging and decrease diseases while supporting each other in the community. It is not a system, but it is something we build together with people in community taking times. And this connection is wider than that of comprehensive community care. That's why I came to know this, and that's why I wanted to execute Chiki Marugoto Care in my visiting station. These are the needs for super aged society. People aged 75 and more have chronic diseases, and there are no need to have acute care, but needs to adjust their lives to their aging and diseases. And this bracket needs support and needs to participate in society. That's why I thought we need local community care that can protect the integrity of their lives. This is the demographic data of Saiwai City, Kawasaki, where I work. And this graph shows the ratio of people aged 75 and more. And dark red indicates area with higher rate of aging population. This map shows the ratio of population who is younger than 15. Dark blue area has high rate of children, more than 20%. As you see, demography varies by area. So I thought we need to consider the health of both elderly and young people from perspective of nursing. From visiting care to community care, we should consider a community as a whole. We have combined nursing with local welfare and made use of local resources such as people, goods, event, and space to let people participate in society. We provided care while engaging in community management. In other words, we made a shift from individually separated care to person-centered community care. These are the places for activity-based rehabilitation, like zoo or vegetable outlet and so on. And we made use of nature and art to support people's life. And we are challenging to deal with health issues in big cities. Big cities is overflowed with acute care and specialized hospitals. People visit different specialists, which leads to polypharmacy or not being able to receive appropriate care. And there seems to be much weight on the medical care in their lives. In order to provide continuous care, integrated care management with efficient community care and multidisciplinary approach have been practiced. And among them are the support for hikikomori, social withdrawal, or those who is in trouble or worried. These people are difficult to intervene and take time to let us care for them. And even if they want to be supported by community, what I felt is that the lack of personnel who act as a bridge between those people and community welfare. That's why we started volunteer. For example, we made approach to one hikikomori person, and he gradually starts to feel like riding bicycle, and we trained together, and now he has become a paid volunteer. And another hikikomori person went to support office to cook meals, and now this person started to deliver meals to other people in community. As we visit around houses riding bicycle, we try to greet and say hello to everyone, including homeless, and build relationship. By reaching out these people, we are able to build a relationship, and now we are communicating with them about coronavirus or about typhoon. And this is not in our system, but we are engaged in child rearing support since our station happened to be in the area of high rate of children. We did volunteer activities, and we are consulted by child rearing mothers that during the pandemic, there were no places for children to play around. And so we cooperated with health worker and prepared swimming pool and held other events, so that instead of just focusing on prevention of disease, we wanted them to have hope and healing. We also consulted with photographer and were able to hold various events. We want to build a community where the people can freely express their feeling. What we aim for is to live together in the community with comfortable connections. Please take a look at this big banner. This was created by a child rearing staff with her children in April, and they asked me to place this, and we put it outside the balcony. It reads, "You are not alone, please contact us." And in response, on the Mother's Day, a local resident brought this object to the entrance of our building. We don't know who made this, but I was so impressed to know that message from the children were truly conveyed to the community. This is a community knitted together with people who can make most of their capability and play a central role in their lives. We want to expand Chiki Marugoto care so children can feel safe even at the event of emergency. And as a resident of this community, I want to be proud of myself as a nurse, and I would like to create a value in this work. I would like to continue to explore nursing, which is the science art. We aim for healthcare, leaving no one behind. We would like to engage in creating a community for realization of inclusive society. We would like to co-create the care system with local residents and grow our community. Now we want to move on to discussion about nursing, future nursing.
On the presentation by Japanese.
And I actually have two kinds of comments to make. One of them is back to Atsuko's introduction of herself. And what she didn't say was that she's responsible for sponsoring and supporting and advancing nursing in so many different ways. So you occupy a special place in nursing, even though you're not a nurse. So I wanted to acknowledge that. And it's always an honor to be with you. The second thing is that I thought that the presentations really demonstrated the major themes that I think are part of what is common among each of these programs. And one of those themes is a deep commitment to serving the community and a profound connection with what nursing can do and a commitment to advancing nursing's capacity. A third dimension, though, I would mention quite sincerely, is that these are powerful women who are doing this work. And I have such respect because this isn't easy work. And you've been able to do remarkable achievements. And the platform that the Sasakawa Foundation has provided for developing that leadership component and the skills is quite impressive. So those themes of being leader, committed nurse, and someone who cares about the community deeply are very evident across those examples.
I remember when Dr. Kita talked about the program at the beginning of the program, and I also had an opportunity to present to one of the classes that were going through the program, with how you took the concept, the idea, the learning, and took it to practice. And I'm also very impressed how nurses becoming entrepreneurs in managing their own practice and providing the leadership. What we have been able to do in Canada, while you develop the concept of home care, you also develop the social care and really looking after the whole community in a very integrated, supportive way. It's shown in an OECD report that came out 2 weeks ago. The life expectancy in Japan is growing, as we know that you have excellent life expectancy, but it's growing. So the support and the programs that you're putting in place hopefully will be scaled up across your country, and all seniors and those that need the support could benefit from it.
Andrea and Mara, do you want to add more comment to, in addition to Judith?
I would like to build on something that Judith mentioned, and it's really nice to see you. It's great having you. And that is this whole interest in the economic side of this. And I noticed, Itsuko, that you're really at a very critical moment, and it relates to how we can transition all of these enterprises from that startup, which is so magnificent, the training and the preparation and the network development that's happened, to scaling these enterprises to the point where they're sustainable and also where they are replicable by others. And one of the powers that I see in this group now is that you are a collective in addition to being individuals. And by being collective, by being connected in a network as you are, it's a very strong thing and can potentially be used in the future for everything from quality assurance kinds of connections, training, even finance. So I just wanted to add that because this critical moment that you're at, you've accomplished so much. It's a critical, important moment, and you have in place the platform, as Judith mentions, from the amount of development that's taken place from that original vision to where it is now, to take it to the next step. And it's critical for this world that we have what you offer.
How about Andrea?
I guess, one of the further questions I had, with COVID, there's been a real problem of isolation and loneliness and people in their homes and people being alone and very vulnerable populations. And I was wondering, again, these centers seem so organized. what type of services are they offering, or how are you able to continue to offer service in these difficult times where people are alone and it's very hard to reach them? So I just wondered if there was any observations or what you're doing about that. Because I know in Canada, we have services, but we're not very well organized in terms of the community sector, the way your centers came across.
We have been always communicating with them. We go around people's house by bicycle, but whenever we go, we talk to them and communicated with them. And the pandemic happened to happen, and now we communicate about pandemic. And when there is a typhoon in the forecast, maybe I can advise him to evacuate early, or maybe you should stay at home on that date. And what we are now doing now is that we thought we should not be the only one to communicate with them. So I talked to the staff of convenience store and local shop, and I informed about those who are suffering or in need by using their nicknames. We called them by nicknames. And then what we found was that they were already aware of those people. And by engaging these people in the community, it seems that more attention are being given to those people in need.
Are evident in these that aren't necessarily partnerships with healthcare providers at all are so important. And that was a theme that I saw throughout here, was reaching across these professional boundaries, not being stuck in talking to only nurses, working only with nurses, is working outside and using every resource that's possible. And that's very impressive.
My comment, following up to Marla's comment about partnership, I think the whole program is an exemplar for partnership, because while I know that the Japanese Nursing Association was a partner, without Dr. Kita and the Nippon Foundation, this would have not happened. And I think we don't have too many examples where we see global foundation that focuses on specific home care or nursing agenda and puts in the resources and the efforts to make that happen. So I think that level of partnership is extremely crucial. And the one thing I would say is that I believe that the time has come, Dr. Kita, for the collective you to put out a book, not just in Japanese, but in English also, because I think there are a lot of lessons that many of us can learn from what you have done.
Well, I have read all the people's presentation in short time. And now in the world, we are now facing with the crisis of COVID-19. And Dr. Chaman mentioned about the new role of nurses at this emergency. And Dr. Andre Bang, at the last part of her presentation, he quoted Dr. Hinohara's remarks. Like, under the crisis, we have to cooperate like climbers which share one rope to survive. And under these circumstances, this is not related to this session, but each one of us nurses should act hand in hand so that we'll be able to fight against this pandemic. And hopefully each one of us would have such sense of mission. Well, I myself read the book of Nightingale, and I became a nurse because I wanted to be someone who can reach out for people. So I hope the nurse should not act alone. hopefully we want to cooperate. Well, this was my message. This is not related to this session.
Yes, in my opinion, I am not very arrogant to dominate to nursing society, but I think nursing is a universal humanitarian science. So I believe in this unstable world, only nursing can contribute to any person in any place, any country, either rich or poor. We need to keep health, and nursing is the only tool for people for them to keep their health. So I hope not only Japanese nurses, but also global nurses can make very close communication to promote health, not only the individual health, but also health of the community, health of the country, health of the world. So that is the reason why I opened this big project. But fortunately, with Dr. Judith, Dr. Andrea Bowman, Dr. Vala Salmon, we have very big supporter to our project, in my opinion. So I hope in future we can expand our activity, not only in Japan, but also in many countries. That is my conclusion, Chaman.